Everyone, welcome to researchmd.com. Another great presentation. We're going to teach you everything about obstructive sleep apnea, very common in society, right? And again, my name is Pramil, Cheriyath. I'm a program director in internal medicine residency, transitional residency. I teach medical students in residency, also director of research. So our goal is, again, my friend, teach you everything obstructive sleep apnea under 9 minutes. So make sure you repeatedly watch it so your knowledge is going to stay in your brain for a long time, okay? So definition is sleep disorder. You have to know something called apnea and hypopnea. There's like, when you talk about apnea, that means like a peak signal excursion by greater than 90% for like greater than 10 seconds. And then hypopnea is peak signal excursion drop by greater than 30% for like greater than 10 seconds and greater than 3% oxygen desaturation or even associated with the arousal, okay? Those are two terms you need to know when you talk about obstructive sleep apnea. And then we can define this apnea and hypopnea index, okay? So you calculate the apnea hypopnea index. If it is greater than 5 events per hour, then you can, that is what obstructive sleep apnea. So 20%, so more in men. Again, 10 to 40% prevalence is common also. If the obstructive sleep apnea, we have apnea, hypopnea index is greater than 5 events per hour. So what are the risk factors? Like obesity is like a major risk factor. Heart failure, atrial fibrillation, treatment of refractory hypertension, type 2 diabetes, nocturnal dyspnea, stroke, pulmonary hypertension, high-risk drivers, and all of that risk factors for obstructive sleep apnea. And additional risk factors, you talk about small lung volume, factors impairing upper airway anatomy, fluid retention and shift of fluid overnight from leg to the neck, male sex, which you already talked about it, older age, menopause, smoking, and exposure. So obesity is the most common, always kind of remember that, okay? The other causes like periodic complexes like causing apnea or partial causing hypopnea, collapse of the pharyngeal soft tissue during the sleep is contributing it. Let's look at a little bit of the pathogenesis. How does it affect our body and how does it happen? Airway patency. How do we measure? How do we keep our airway open all the time? There's a balance of forces, right? There's the musculature, there's connective tissue, intra and extraluminal pressure. All of this balance to keep our airway open. In upper airways, the more collapsible in this patient with obstructive sleep apnea. During wakefulness, pharyngeal dilator muscle can compensate sufficiently to maintain adequate ventilation. During sleep, compensation by dilator muscle is insufficient, then it collapses, and then you can have obstructive sleep apnea, okay? So what are the criteria to diagnose? Use the stop bang criteria. You got the nice mnemonic. You look at the snoring, tiredness, obstructive apnea, high blood pressure, BMI greater than 35 kilograms per meter square, age greater than 50, neck circumference like greater than 40 centimeter, gender. So you put those and you look at the score. The sensitivity is like 84% and specificity of 56%. So if it is score is 5 to 8, the high risk, okay? And the symptoms, usually people like, you can always the people say like frequent awakenings, okay? And then you can have like worsening, witness apnea, then take a deep breath and they don't breathe for like 30 seconds. And sometimes, usually when they get up in the morning, they always have like the early morning headache because of CO2 build up in their system, okay? You can have nocturia, and then you have drowsiness during the day. Daytime sleepiness is the other thing. Now, whenever we talk about international classification of sleep disorders, let's look into their classification. Both clinical signs and symptoms and evidence of obstructive respiratory events. Presence of greater than one of the following: sleepiness, non-restorative sleep, fatigue or insomnia syndrome, awakening with the breath holding, gasping or choking, bed partner or other observer describes snoring or breathing interruptions. Remember that. Hypertension, mood disorder, cognitive dysfunction, coronary artery disease, and then greater than 5 predominantly obstructive respiratory events per hour measured by out of the center of sleep testing. That is like polysomnography, right? That is what we do in the main test, polysomnography. And absence of clinical signs and symptoms, but if it's greater than 15 predominantly obstructive respiratory events per hour measured by polysomnography or out of center sleep testing is important. Okay, diagnosis again, we can do like a full night polysomnography. You just have to go to the sleep center, they give you like a nice hotel accommodation, and they put the monitors and they measure all this apnea and hypopnea events. Okay, Polysomnography, just few words, sensitivity and specificity is around 80% and specificity 97%. So very good test indicated. So in uncomplicated adult patient with a suspected moderate severe obstructive sleep apnea, some of those, like, new studies can do like some of the home sleep apnea testing and all that too, can be done, all that. Remember that. So how do you interpret polysomnography? Okay, diagnosis first is like you have to have like polysomnography like 15 events per hour or greater than 5 events per hour in a patient with the typical symptoms such as unrefreshing sleep, daytime sleepiness, fatigue or insomnia, awakening with a gasping or choking sensation, loud snoring, witness apnea. And obstructive sleep apnea is severity defined by if this mild for respiratory index is greater than 5 events per hour and less than 15 events per hour. Okay, all of those kind of, let's say, moderate respiratory disturbance index. That means greater than 15 events per hour and less than 30 events per hour. And the severe for respiratory disturbance index is greater than 30 events per hour. That's another way to classify obstructive sleep apnea and polysomnography. So the management, the main thing you have to do, again, lose weight, okay? Exercise, postural therapy, avoid alcohol and sedative before bedtime. Continuous, there's the main treatment is like you gave the CPAP, you put the mask on and you sleep trying to do this. So many new devices, even work on remote control, very comfortable. So continuous airway pressure, that's the main treatment, but lifestyle modification is important. There are no medications, and some people either enroll for surgery who cannot treat with a CPAP oral appliance, but it's not very clear. I mean, how long the effect surgery lasts also. So the complications of obstructive sleep apnea can lead to so many things later on. Mainly respiratory complications are very common in these people. You can even cause like high blood pressure, heart attack, atrial fibrillation, heart failure, stroke, diabetes, liver problems, sleep-deprived partners. A lot of complications. You can cause pulmonary hypertension because the heart is not getting enough good oxygen supply and all that. Okay. Thank you so much for watching. We'll be back with another presentation soon. Thank you.